Where do I need to stand to be?
Yep.
Okay, so this is the roundup for week 4, and this is where we were focusing on red cell inclusions and macrocytic anemias. So I'm going to turn off the light now so that we can see the films more easily, and I'll go through the films one at a time in the next 20 minutes.
Is your projector on?
Yeah, it's on mute. Okay, so this is the first blood film, which is patient 2.7. So this is the patient who had,
Sorry.
that's okay, you just have to see in the dark. This is the patient who had a known beta thalassemia, but they were querying G6PD deficiency in a crisis. So can somebody on, perhaps Max or Gabby, can you tell me that querying of G6PD in a crisis, what would you be looking for in that sort of situation? Can you think? Can anybody think at all?
White cells?
Yep, so we might see bite cells. What else might we see? What sort of a condition is G6PD deficiency? What have we been learning about for the last 3 weeks? It's normocytic. It's a normocytic anemia. And what sort of normocytic anemia is it? Is it hyperproliferative? Is it hypoproliferative? Hyperproliferative, yes. So we've got an increase in our bone marrow function. So we know it's a hyperproliferative anemia. Is it due to something that has gone wrong within the red cell, or is it due to something that has gone wrong outside the red cell? Where do we find G6PD? What is that and where do we find it? So it's an enzyme that we find in the red cell. So this is hemolytic anemias due to intrinsic defects, yes? Okay, so if we've got a hemolytic anemia, we talked last week about what the hallmarks of a hemolytic anemia are when you look on a blood film. There are 2 cells that we very often see. Spherocytes and what tells us that the bone marrow has increased its production of cells? What sort of cells? Reticulocytes. Okay, so we often see spherocytes and reticulocytes when we have hemolysis. And there's a lot going on here, but in this film you can see that there are spherocytes there, and there is also polychromasia. There's a lot else going on as well, but there's definitely some spherocytes. So these dark cells, spherocytes, and there's also some slightly larger. These ones are more purpley. That one in particular is more purpley. And so there is some polychromasia going on here, as well as all of the other things that are more associated with the fact that there is a beta thalassemia underneath. So beta thalassemia, as you learn about next week, is one of our microcytic anemias. So that's why when you first look at these cells, the first thing that would have struck you, I would have hoped, was the fact that they're quite little. They're quite small, and many of them are hypochromic. So right down in the corner here, if I can get it properly focused. What's that cell down there? It's a nucleated red cell. Have a look at the colour of the cytoplasm compared to the red cells around it. It's the same colour. Okay, so it's that hemoglobinised colour. And the other thing that was in this film, oh there you go, you can see it right down the bottom there. I'll point the cell out to you and then I'll focus it. See that cell there? People at the back may need to come up to see that, but I think most of you did see it on your films, and that is basophilic stippling. Did that come up on the video?
Yeah.
Yeah, beautiful. What else is in there? Oh, the other thing that I really liked in this film which of course is in my field of view but not yours. And I'll see if I can get it into your field of view. If I go up, there we go, look at that. So what's that cell there, given that that cell down the bottom is a nucleated red cell? It's a lymphocyte. Okay? So that's the main features of that. And the thing that I really wanted you to see was the basophilic stippling that's in the cells, and also, again, helping you with your recognition of nucleated red cells and the fact that there is polychromasia and spherocytes here. So we've got a hemolytic process going on here. Okay, so the sort of thing that you should have, the other thing that was in this film too was the fact that we had 20 nucleated red cells per 100 white cells. So guys, did you do a corrected count? What did you get? 4.8. So 4.8, so 4.7, 4.8, something around there would be right. I got 4.8 here. So what you then do is the differential count, the percentages that you did yourself, you would then calculate the absolutes on that corrected count. Okay? As I said, you've been given two formulas that actually do give you the same answer. The formula that we used last week is a simpler formula. I don't really mind which one you use because it's not so much about you memorising the formula, it's about you telling me why we need to correct the count in the first place and what that corrected count is. Okay, I don't care how you get there as long as you get there and you understand why you're doing what you're doing. So the significant features of this film are the fact that it is a microcytic hypochromic anemia, and that we can also see, so that's consistent with the history, the known history, and the fact that we have spherocytes and polychromasia there tells us that we have got hemolysis there. So again, that's perhaps confirming what they suspect, that this person has a G6PD deficiency in a crisis. So having been given that, Belinda, can you remember what we would do to determine whether or not this person has G6PD deficiency? What sort of a test we would do? What was that test we did where we had to pass the... So we could either do a spot test for G6PD deficiency. Remember when you came up the front here and you had to pass your filter paper with the spots over the fluorescent light? I think that was only 2 weeks ago. Long time ago in university terms, isn't it? Or you can do an assay for G6PD deficiency. Okay. Has anybody got any questions about that blood film? No? Okay, let's go on to the next one. So you can see in the field that I'm on, you can't possibly tell anything about the morphology of the cells in that field. You're too far up the field, you're too close to the top where the blood drop was put onto the film and the film was spread. So you need, and that's what we call the head of the film. So you need to go down to the other end. But while we're here, it's a real pity that artefact doesn't really show up well here. When I look down my film, my camera, I'll get it in a minute, my microscope, I can see quite a bit of refractile water artefact there, but it's not really coming up on that film. So I'm just going to the 10 times and I'm going to blow it out. So this is the other end of the film. This is the tail of the film. And the reason that we don't look at the morphology in the tail of the film is because you can see that the cells are all clumped and clustered and the white cells tend to get caught up in the tail, and they can give you an incorrect differential count. So the trick is to find an area to have a look at your cell morphology just up from the tail where you start to see the cells being more evenly distributed. So again, this is quite a hard film to do that on because we have so few cells. Okay, so again, the first thing that strikes you is the fact that we have so few cells, and look at that difference in the size of the cells. So that's quite a significant anisocytosis that we've got there. And we look at the RDW and it's 24%. And I can quite understand why. We've got some whopper cells there. So these ones down here, look at how big those ones are. Sorry, that was not the RDW, that was the RDW, the last one, which had a lot of differentiating. The RDW is quite big on this one too. It's not as big, it's 18%, so it is still quite high. So what do you think that cell is in the middle? It's a very big cell, isn't it? So that's probably even a bit earlier than a band form. So that's probably a metamyocytes, which is an earlier white cell. But you can see these white cells are giant. And I'm just trying to have a look on the neutrophils are giant. I'm just trying to have a look for a lymphocyte to see if we can check out the size of the film, or the size of the cells. And the reason I asked you to do a diff count on 50 cells is because the white cells are so few and far between. So there's a lymphocyte there. Now that some of the cells close to that lymphocyte are looking fairly normal in size, but when you look at the other cells that are in that field, they're actually either the same size as that lymphocyte or they're larger. Okay, is everybody happy with that? And the other thing for you to notice that there are many oval red cells. Many of the cells are oval in shape, some of them are round, but there are a lot of oval cells there. The other thing for you to notice is, can you see it there? There's a little bit there. So in these oval cells, how they've got this little pointy end on them, that's what we call teardrop, and this one here. So that's dacryocytes or teardrop poikilocytosis, and that's very common in this sort of a condition. So the things that you should have noticed here are particularly the fact that the cells are very large, macrocytic. Even though the MCH is 46, which is really high, the MCHC is 340, so that's normal. So the reason that you've got a high MCH is because you've got big cells. Big cells can take more haemoglobin. Okay, Okay, so it's macrocytic normochromic. It's not hyperchromic, it's normochromic because those cells are bigger but they've still got the right amount of hemoglobin in them. The fact that the cells are macrocytic, that they're oval, and that you're seeing that teardrop poikilocytosis. And the other thing that everybody picked up was the fact that many of the neutrophils were hypersegmented. There we go, there's a beauty. So there you go, in that field you've actually got a band form and a hypersegmented neutrophil. And again, that's not uncommon to see the band forms in this form of condition, which is a megaloblastic anemia, because you have got disrupted hematopoiesis. So the cells, you've got accelerated maturation, you've got disrupted maturation, you've got asynchrony between the nucleus and the cytoplasm of all cells, you've got steps in the maturation process being skipped. So you're getting these larger cells that haven't divided properly, and you're getting early cells being put out, as well as these hypersegmented cells. So there's quite a bit going on. The thing to remember with megaloblastic anemia is that all three lines of cells are being affected, and so we end up with a what copy when all three cell lines are affected? A pancytopenia, yes, and we talked about that earlier, didn't we? Okay, so macrocytic normochromic anemia with pancytopenia and hypersegmented neutrophils. So they are the significant features of this film. So you could put something like query-megaloblastic anemia consistent with history, or just query-megaloblastic anemia would be fine. But then your further differentiating tests, Ray, what tests did you put down to do? Okay, so I think I'm hearing you said B12 assay, vitamin B12 assay and folic acid assay. Yeah, did anybody, Max, I know you suggested something else?
Iron studies.
So Max suggested iron studies. So what was your justification for the iron studies, Max?
She's vegan, so they're commonly deficient in iron.
Okay, so this person is vegan, so they're commonly deficient in iron. There's another test that we could do, particularly if the vitamin B12 level was low. What would that be, Sophia? Can you think?
Sorry.
If there's another test, for people who have a vitamin B12 deficiency, there is another test that we sometimes do. Can you think what it is? Can anybody think what it is? Intrinsic factor. So why wouldn't we perhaps go on and do that, given in this particular instance? She's vegan, is that what you're saying? And she's her age? Sorry, Mohammed, I can't see you again. You're quite stark. But that's why she's 32, and pernicious anemia is much more common in older women. But certainly, if she did not respond to the B12 treatment, then they would look further to see why she's not responding. Has anyone got any questions with that film?
Did you see any? I thought I saw like spherocytes.
You saw some spherocytes there? It wouldn't surprise me. Yeah, microspherocytes there as well, because you've got to remember these cells are very big, and so going through the microvasculature, going through the spleen, they're going to get stuck, they're going to get bits taken out of them, and so it wouldn't surprise me seeing spherocytes there. Okay? Well done. Right, so
Jane, sorry. So one of the questions is identify another common health condition that is at risk of developing in life.
So the other common health condition is iron studies, particularly in women of childbearing age. And finally, I'll just notice what the time is. So this is film 2.2.1. I'll do the right thing and go down to the 10 times first. So we already have a clinical history of alcoholism. Well, Nettie. So you can see here how all of these white cells have been caught in the tail here. So that's why you don't do a differential count in the tail. So what is significant about our full blood count numbers? What is significant? What is different? Not what is abnormal? Is the red cell count abnormal?
Yes.
Yeah, so it's low. What about the hemoglobin?
Slightly.
Yeah, so slightly low. So for the red cell count, you should have got something like 4.2 or 4.22. For the hemoglobin, you should have got something like 127. Yes? Okay. So the other significant features here are that the red cell count is low, but the platelet count is low normal and the white cell count is normal. So we do not have a pancytopenia here, even though the MCV is 109, so we do have a macrocytosis, but we do not have a pancytopenia. That's why identifying that pancytopenia is so important in macrocytic anemias. We can get pancytopenias in other things as well, but in macrocytic anemias it is a very good indicator that we have a megaloblastic situation. So when we look at our cells here, so you may recall that I talked in the lecture in the sheet about the fact that in these macrocytic anemias, particularly where the plasma lipid ratios are different in the cell membrane, that the neutrophils, they're not toxic, but they're certainly different to what you would expect to see. You can see the granules very easily, and of course they are quite large, and this is what I refer to as my angry neutrophils or my upset neutrophils. So they're not toxic, but they certainly look different to normal, and that could just be that the cell membrane is a little bit thinner, or it's a different constituency, different chemical constituency, and so the cells are staining a little bit more, a little bit differently. So there's a little lymphocyte there. And so again, you can see from that lymphocyte that the cells are larger in size. What's the other thing that you can see lots of here?
Target cells?
Target cells. Lots and lots and lots of target cells. And while target cells can be seen in many conditions, when we see it in a macrocytic anemia like this, what would it suggest to us?
Alcoholism.
Yep, so alcoholism, not so much alcoholism as liver disease. And of course, alcoholism is the most common cause of liver disease, but there are other causes. Can anybody tell me another cause of liver disease? Viruses, yeah. So hepatitis C, Hep B, Epstein-Barr virus, HIV. There's a lot of viruses that affect the liver and attack the liver. So these cells are looking a bit more toxic. And again, I don't know if you can you see the dark, really dark granules in that neutrophil?
Yeah, I had a few that I was pretty sure were toxic.
Yeah, so there are a couple of toxic neutrophils around, although they're not mentioned here. Right, so when you did your diff, so you should have got something like neutrophils 89, lymphocytes 6, monocytes 4, eosinophils 1. And did anybody see anything significant with the neutrophils? With your white cell count? The answer to that is there is a neutrophilia. How many people noted a neutrophilia? Yep, even though the white cell count is normal, there is a neutrophilia. Okay, so your conclusion should have been something like macrocytic anemia with a neutrophilia. So this is, so there could be some inflammation going on there because you've got a neutrophilia there, and also that is consistent with the clinical history. So what other tests would you do in this case? Particularly considering the most common cause of macrocytic anemia. Liver disease. So what would you do to check and see if the alcoholism has caused liver disease?
Liver function test.
Liver function tests, yes. Okay, and because many alcoholics or people with chronic alcoholism also have suppressed appetite or poor nutritional status, you would also do your nutritional tests as well. And when I say nutritional tests, what do I mean, do you think, Joy? What sort of tests are nutritional tests?
Vitamin B12, folic acid, iron deficiency.
Lovely. So vitamin B12 assays, folic acid assays and iron studies. Has anybody got any questions about that one? And I just realised I didn't give you the diffs for the other two. So if we go for film 2.7, the differential count should have been something like 38%, 47%, 14%, eosinophils nothing, and basophils 1. So that's neutrophils 38%, lymphocytes 47%, monocytes 14%, eosinophils 0, and basophils 1%. And for sample code 1.3, with a white cell count of 2.1, the diff should have been something along the lines of neutrophils 52%, lymphocytes 38%, monocytes 5%, eosinophils 4%, basophils 1%. Don't worry if you didn't see any basophils, there was only 1% in there, so only 100 in 100 cells. Okay, has anyone got any questions before we pack away for the skills test? All right, let's get going.